We are going to discuss acute coronary syndrome and acute myocardial infarction. Here are your objectives related to ACS and AMI. Your heart is a glorified pump, and what it does is it is going to contract, allowing for oxygen rich blood to be delivered to the tissues and cells. And your heart is going to be primarily perfused by your coronary arteries. So, most of the oxygen and nutrients that the heart receives are going to be from these two main coronary arteries. First, you have your right coronary artery, which is going to perfuse the right side of your heart, including your right atrium and your right ventricle, and parts of the septum. And the right coronary artery is going to branch into smaller segments, allowing it to perfuse more areas. And these can include the right acute marginal artery, and then you also have the right posterior descending artery. Just like with your right coronary artery, your left coronary artery is going to branch off into smaller arteries, allowing for it to perfuse more parts of the heart. And your left coronary artery is especially important because it is going to perfuse the entire left side of your heart, including the left atrium, the left ventricle, and parts of the septum, as well as the SA and AV node. And I want you to think about what the right side of the heart does versus what the left side of the heart does. So you can see just how important this is. Your right side of your heart is going to pump oxygen rich blood just to the lungs. Now, remember, your left side of your heart is going to be responsible for perfusing the rest of the body. And I'm not sure if you've ever heard of the term widowmaker. Your widowmaker is your left main coronary artery. And they call it that because when you have coronary artery disease that leads to infarction in this widowmaker, it often is going to affect such a large part of the heart so that so much of the tissue dies, leading to death. Coronary artery disease is going to be the most common type of heart disease seen in the United States. And this is going to be caused primarily by atherosclerosis, which is going to be that thinning and hardening of the arterial wall. And this is going to lead to something called plaque buildup or formation. And plaque is generally going to contain substances such as cholesterols and other fats. It can contain things such as calcium and other goodies, but it's going to be primarily that cholesterol. And it's going to build up along the wall, causing endothelial damage. And remember, when we have damage, what's going to happen? Our body is going to try to repair it. So our platelets are going to come, they're going to go, hee! And try to fix this damage. But this is going to lead to even more obstruction. And eventually, that plaque can rupture, leading to complete blockage of that coronary artery, meaning that infarction is certain to happen. Non-modifiable risk factors for coronary artery disease are going to be increased age, male sex, and certain races or ethnicities are going to be more prone, such as African Americans, Mexican Americans, Native, Alaskan, and Asian Americans. But we have modifiable risk factors, and this is generally what we focus on because this is where we can promote change. I'm not going to educate my patient, hey, you're old, I need you to get a little younger so you'll be at reduced risk of coronary artery disease. That's not going to work. We are going to focus on those modifiable risk factors such as diet, activity level, obesity, smoking, hypertension, diabetes, metabolic syndrome, hyperlipidemia, stress, excessive alcohol use, cocaine or methamphetamine use. Coronary artery disease is going to result in reduced blood flow to the heart, which can lead to ischemia. And what is your hallmark sign of ischemia? Pain. Now, you're probably most familiar with stable angina.
Stable angina is going to be chest pain that occurs during activity. Because remember, during our activity, our myocardial oxygen demands are going to increase. But because we have decreased blood flow, we are unable to meet the heart's new demand. And that's why this type of angina is going to be present during activity, and it usually is going to reside within 3 to 5 minutes of resting or taking nitroglycerin. You also have something called unstable angina, and that is going to be angina that is going to occur at rest or with minimal activity, and it's going to consist of prolonged or increased pain, and it is not going to resolve with nitro arrest. And this is a medical emergency. This type of angina is going to be part of acute coronary syndrome.
ACS is just a umbrella term used to describe three different disease processes that are all characterized by ischemia. And whether we are talking about unstable angina, a non-STEMI, or a STEMI, these are all medical emergencies. And because they are all characterized by ischemia, you're going to have similar symptoms. However, with unstable angina, you have ischemia and no injury. But with your non-STEMI and STEMI, you're actually going to have injury or infarction. So your unstable angina is going to be different than your stable angina. With this type of angina, it's going to be caused by a non-occlusive thrombus. So you're going to have pain at rest, or it's not going to be improved by nitroglycerin or by rest. It's going to be unpredictable. And with this, you're going to see non-specific EKG changes. A lot of times you will see ST depression because that means ischemia. However, when we do the cardiac biomarkers, you're going to see that the troponin is not elevated. And that is because your troponin is going to be an indicator of cardiac injury. And with unstable angina, you just have the ischemia. You haven't reached that injury stage yet. Your non-STEMI is going to be caused by an occluding thrombus that is going to be sufficient enough to cause ischemia that ultimately leads to injury. A lot of times you'll see ST depression, and you may see T-wave inversion. And how you distinguish this from your unstable angina is because your cardiac enzymes will be elevated because you actually have injury to the myocardium. And your STEMI is going to be caused by a complete thrombus occlusion. And this is going to lead to damages to the SA and AV node, leading to ST elevations. Also, you may see a left bundle branch block, which if a patient shows up with signs of an acute myocardial infarction and you see a left bundle branch block on the EKG, I want you to assume infarction, because a lot of times that ST elevation can be hiding behind that left bundle branch block. And with your STEMI, since you have complete thrombus occlusion, your cardiac enzymes are going to be even generally more elevated than with your non-STEMI. And your symptoms are generally going to be more severe because you have complete occlusion. So just remember, unstable angina is going to be your ischemia, no injury, and your non-STEMI and STEMI are going to be ischemia that ultimately lead to injury. Since chest pain is very similar with your stable angina and your acute coronary syndrome, it is very important that you understand the differences in how chest pain presents with these patients. For example, remember our stable angina is just a supply and demand issue. Anytime our demand increases, we may not be able to supply adequate oxygen. And that's why the symptoms are usually very short in nature. They can be relieved by rest, position change, or nitro. All we have to do is increase the supply to meet the demand. And a lot of times it's going to be caused by exercise, activity, strong emotion, and general stressors to the body, and even a big meal. And remember, supply and demand issues, so it's going to be short in nature. And a lot of times patients are going to describe this as tight, squeezing, constricting, heavy, and they may have symptoms because they are having ischemia. They may have some dyspnea, some tachycardia, and this can lead to things such as fear and anxiety. And our atypical manifestations are going to be very similar to indigestion, upper back pain, nausea, and vomiting. Now, with acute coronary syndrome, you're going to have pain at rest. And that is because, remember, you're going to have either a non-inclusive or an inclusive thrombus. So it's not a supply and demand issue. And there is going to be no relieving factors, unlike with your stable angina. And a lot of times patients are going to describe substernal or epigastric pain. It may radiate to the neck, left shoulder, or jaw, or left arm. And it's generally going to be longer in duration because remember, it's not a supply and demand issue. It's going to be pure ischemia. And patients are generally going to describe it as different than their typical chest pain. You know, patients who have stable angina, they're going to be able to tell that this is different. So make sure that you're listening to your patients. They're going to say that there's a new onset or the pattern is increasing in severity and frequency, and they're likely going to have more severe symptoms than with your stable angina. I'm going to do a quick review of everything I just said. So, we know with coronary artery disease, we're going to have atherosclerosis, and because of this, plaque is going to form on the arterial walls. And over time, this can build up and eventually rupture. When there's just a buildup, we'll generally have stable angina. And we remember that stable angina is just a supply and demand issue. The only time I have chest pain is when my demand increases and my supply cannot meet that. So if I rest or take a vasodilator like nitroglycerin, it'll easily be fixed. With unstable angina, you know you're going to have that non-occlusive thrombus. Likely you've had some plaque rupture, and ultimately it's going to interrupt that blood flow, leading to ischemia. And this is part of ACS. It's a medical emergency because at rest, we know that we have such a large blockage that we cannot properly oxygenate the heart. And we know with our stable and unstable angina that we just have ischemia, but we don't actually have injury. And when we develop injury, that's when we have ischemia that is so prolonged that the tissue starts to die. And that's going to be our non-STEMI and our STEMI. And with our non-STEMI and STEMI, you're going to have increased cardiac biomarkers. Why? Because you have injury to the tissue. With our stable angina and our unstable angina, we are not going to have increased cardiac biomarkers because we just have injury with no actual damage. Now, I want to talk about some special populations because women are much more likely to have atypical or non cardiac symptoms. Women may just have some shortness of breath, fatigue, weakness, hiccups. They may exhibit weakness in the arms or shoulders. And this is going to often cause them to delay seeking care, leading to worse outcomes. And older adults may also have that atypical symptoms, and their complaints can be very vague, such as dyspnea, confusion, dizziness, syncope. And they're going to have a high prevalence of silent ischemia as well, which can also delay them in seeking treatment. And diabetics, remember, diabetes is going to lead to neuropathy and it's going to alter those pain pathways. And because of this, diabetics may present with those atypical symptoms as well. They may just appear with numbness, or they may not experience pain at all because of that neuropathy. You will see a variety of different tools used in the diagnosis of an acute myocardial infarction, and some of these are going to be diagnostic in nature, such as your troponin, your 12 lead EKGs, and your cardiac caths, while others are just going to help us monitor the progression of the myocardial infarction or the extent of the damage, such as an echocardiogram. That's going to show us any structural damages. And you'll see things such as myoglobin, CK, and B trended too, but that's not very specific. But generally, you'll see that we will trend troponin, we will do serial EKGs to kind of monitor if the infarction is resolving. For example, if my acute infarction is starting to resolve, I would expect my troponins to trend down, or I would expect to see less ST elevation on my EKG. But if it's worsening, my troponins are going to skyrocket. You're going to see worsening ST elevation on your EKG. And your cardiac cath will show how blocked the artery is, but it's also a way that we can provide treatment to the patient. And you may see other labs ordered and monitored, such as your lactate. Remember, lactate measures perfusion. You may see a BNP, not BNP, BN as in norepinephrine. And that is just going to be something we see because this is going to be released when there is severe damage or heart failure. So this can help us determine if the patient is in heart failure. We may also look at things such as a CBC, a CMP. You may see them look at coagulation factors, just about anything to just kind of monitor the patient's general status. We know that we have the two main coronary arteries that are going to branch off into smaller areas, and each of these areas are going to perfuse certain parts of the heart. So when we are classifying myocardial infarctions, we're going to do it by the part of the heart that is effective, and that is going to be dependent on where the blockage is in what coronary artery and which parts of the heart it perfuses. So we generally are going to classify them by anterior, lateral, inferior, posterior. You may see septal involvement. And then we're going to classify it by the EKG changes it causes. A STEMI is going to be ST elevation. You're going to see that there is ST elevation in your leads in whatever part of the heart is effective. And then you have a non-STEMI, and you're usually going to see non-specific EKG changes, or most of the time you'll see ST depression in whatever part of the heart is affected.
I want you to be aware that you're going to notice many pathological changes in an EKG both during and after the resolution of a myocardial infarction. Now, what is an EKG doing? It's measuring the electrical conductivity of the heart. Let me ask you a question. Does electricity go through dead tissue? No. Does blood flow go through dead tissue? No. So, of course, you should expect some residual changes in the EKG because the parts of the heart that are affected are no longer functioning. Electricity is not running through them. So, a lot of times after the resolution of the infarct, you'll notice that the patient may still have pathological Q waves, And that may be a permanent change in their EKG. Now, generally, ST elevation is going to indicate acute injury. And shortly after the resolution of the acute MI, you are going to see the EKG slowly return to baseline. Now, T wave inversion, you will notice that often during an infarct, and that just indicates ischemia. But just look at the differences in the normal EKG versus one where a patient is experiencing an acute infarct. They're very, very different.
When we have an infarction, we are going to monitor biomarkers. You may see myoglobin being monitored, and myoglobin is not very specific to cardiac damage. Myoglobin is going to increase anytime you have damage to any type of muscle, including skeletal, smooth, or cardiac. However, it is the first enzyme to start increasing after a myocardial infarction, but it could also be increased for many other reasons. But this one will generally start increasing between an hour and a half to 2 hours after infarction has begun. And next, you may see them monitor your CKMB. This is a little more specific than your myoglobin because it's going to be elevated when you have damage to skeletal or cardiac tissue, but again, not very specific. And this one's going to start increasing anywhere from like 2 to 3 hours after the onset of infarction. And more specifically is going to be your troponin T. This is very, very specific to cardiac muscle. And if your troponins start to elevate, you have damage to myocardial tissue. And it is generally going to start elevating within 3 to 4 hours. It'll generally start to peak within that first 12 hours, and then it'll slowly trend back down. And within 7 to 10 days or 7 to 14 days after infarction, these numbers will return back to normal. So when our troponin is elevated, we know our patient is having acute necrosis, acute damage. And let's say a patient had a heart attack, didn't realize 3 weeks ago. Well, we're not going to see elevated troponin at this time because that's only going to be present during that acute infarction. And so we're going to use troponin to trend to see our progression of the MI. If the patient is getting worse or the infarction is spreading, we would expect that our troponins are going to increase as well. Or if a patient has a STEMI versus a non-STEMI, because remember, a STEMI is complete occlusion, generally your troponins can be much higher. I've seen them in the 30, 40,000s. A non-STEMI is generally a less severe form of a heart attack because you only have partial occlusion of that coronary artery. However, these can still lead to death. And with non-STEMIs, you're going to see a lot of ST depression, which indicates ischemia, but you don't have that ST elevation because the damage isn't quite as extent to where the conduction system of the heart is being affected. So you will just see those signs of ischemia. And the prognosis for a non-STEMI is going to be very dependent on the severity of the blockage, the area that is being perfused, the patient's overall health, and most importantly, the time to treatment. With non-STEMIs, we have a part of the heart that is dying, and we need to promptly address this. So the patient may need a PCI, they may need supportive care and medical management. Sometimes you'll see thrombolytics. And the goal is to ultimately stop that expansion of the infarction. You will see the increase in troponins and you will see those EKG changes. And you can trend the troponins and EKGs to kind of monitor the progress as you're providing prompt treatment. A STEMI or an ST elevation myocardial infarction is going to be characterized by ST elevation. And with this, what's going on is you have a complete occlusion to that coronary artery. So wherever that occlusion is, that part of the heart is getting zero oxygen and infarction is imminent. And we know with our left main coronary artery, that is going to be the area that's going to perfuse the largest part of the heart. And that is why we refer to it as the widow maker. And with ST elevation, you have so much damage that it is interrupting that conduction system of the heart. And so you need to remember that time is muscle. And a patient is going to need immediate reperfusion therapy, whether that's a PCI, whether you start them on thrombolytics or a heparin infusion until you can get them to the cath lab, or in some cases, a patient may need a cabbage, but you're going to start that supportive care and thrombolytics or anticoagulants immediately because you want to try to restore that blood flow. And you're still going to provide that supportive care, such as giving nitro, morphine, and things like that. But the ultimate goal is reperfusion. Most of the time, when a patient has an infarction, they are going to have damage to the left side of the heart because most of the time you are going to have blockage in that left coronary artery, which is responsible for perfusing the left side of the heart. And I want you to think about why. Well, for one, the left side of the heart is responsible for perfusing the entire body, so it's going to have a higher oxygen demand. And remember that ventricular wall is going to be thicker on that left side of the heart because it has a bigger job of perfusing the entire body. And because of this, that's going to be more muscle to perfuse. And your right coronary artery, the right side of your heart, has a thinner ventricular wall, so less to perfuse, and the oxygen demands of the right side of the heart are much less than that of the left. So most of the time, patients will present with infarction involving that left ventricle. So why do we really need to know about right ventricular MIs then? Well, here's the thing. Right-sided MIs, although rare, are going to cause a different set of problems. And because of this, you will see different symptoms. And some of the treatments may differ. Ultimately, what is your goal? Reperfusion. But certain medications that we give for the left-sided MI can be dangerous for a patient with a right-sided MI. And with our standard EKG, it is very, very hard to visualize the right side of the heart. In fact, V1 is the only lead that looks directly at the right side of the heart. So it can be harder to detect right-sided MIs on your standard 12 lead. So it's important that you're able to recognize some of the signs and symptoms or clinical manifestations so that you could get maybe a 15 lead or 18 lead EKG so you can determine if it is in fact a right-sided MI if that's what you suspect. Patients with an right-sided myocardial infarction are going to have those general symptoms of an acute MI, chest pain, and signs of poor perfusion. But there is going to be a triad that is going to be seen specifically in patients who have had a right ventricular MI, and that is going to include JVD. When the right ventricle is not pumping adequately, you're going to have that backflow of blood, and that's where you're going to see that jugular vein distension. A patient is going to present with hypotension, and this can either present initially or by giving nitro. They're going to go into severe hypotension. And you'll also notice that they're going to have clear lung sounds because remember, the problem is on the right side of the heart. So the left side of the heart is not affected. So of course you're going to have clear lung sounds. You don't have a backflow of blood going into the lungs because we're on the right side of the heart. What if I told you that with a right-sided myocardial infarction that your treatment was going to be give the patient a fluid bolus? So you have a right ventricular failure, and I'm telling you to give the patient fluid. When have you ever heard someone say give the heart failure patient fluid? Well, in this situation, yes. If a patient presents with right ventricular failure secondary to an acute myocardial infarction, you're going to give them fluid. This is the one time. I'm not talking about a patient who has chronic right-sided heart failure, um, secondary to COPD or pulmonary hypertension. I'm talking about a patient has an acute right-sided MI and now they have right ventricular failure. You are going to give them fluid. And that is going to be because these patients are going to be preload sensitive. And so you need to avoid things such as nitrates and diuretic. And you need to actually give them more fluid to increase that ventricular stretch and help that right ventricle pump more effectively. And so you need to make sure that with a patient, if you suspect or you have confirmed that they've had a right-sided MI, that you do not give nitroglycerin. It is contraindicated, and it can lead to severe hypotension, shock, and ultimately death. So just be aware of that because, we always think heart attack, nitro, right? And that's because most patients are going to present with the left side. But when a patient gives you that idea that this could be right-sided, that's when you take a step back, you don't give the nitro, and you look at the bigger picture. Remember, our standard EKG gives us a complete picture of what's going on with the electrical system of the left side of the heart. Remember, V1 is the only one looking at the right side of the heart. And so there's certain EKG changes along with those clinical manifestations that you need to look for, which may indicate that a patient may be having right-sided involvement. And sometimes when you see that ST elevation in V1, you could see that ST elevation in leads 3, which is going to be greater than that of lead 2. You may see ST elevation in leads V3 through V6, and it's going to be particularly in V4 because that's going to be the most sensitive and specific for determining that there is right side involvement. You may notice some atrial arrhythmias due to that right atrial strain. And when you suspect that right-sided MI, you need to get a 15 or 18 lead EKG so you can see what's going on, because our normal EKG is just not going to show us the clinical picture of that right side of the heart. Ultimately, our goal for ACS management is, if the patient has unstable angina, prevent infarction, restore perfusion. And for a MI, the goal is to limit that in size of the infarct. Early reperfusion is the only way to limit that size. We need to get that patient to the cath lab immediately. So there are certain standards that we must follow. And one of them is going to be from the time the patient has a STEMI and they are in the hospital, you have 90 minutes to get them to the cath lab and get that balloon inflated to start that PCI. If a patient is at a PCI capable facility, or if a patient is not, you have 30 minutes from the time the patient enters the door to start your thrombolytic therapy. And again, this is because your goal is, I need to reperfuse the heart. And in the meantime, you're still going to do supportive care such as aspirin, nitro if it's not right-sided. You're still going to give these treatments, but ultimately you want to get that PCI or you need to start those thrombolytics because ultimately that is what is going to prevent further damage to the heart. When a patient presents with a STEMI, ultimately your first and preferred action is going to be a PCI because with a PCI, it is going to be minimally invasive and it is going to treat that source of blockage. And unlike with your open heart surgery, you're not going to have as many complications. And with the PCI, what's going to happen is the cardiologist is going to insert a thin catheter into an artery in either the groin or now more commonly into that radial artery. And they are going to go to that blocked artery and they are going to pump up a small balloon, which is going to open that artery. And in most cases, they're going to place a stent there to ensure that that artery stays patent. And although a PCI is safe and it's going to be basically your gold standard, there are some complications. For example, acute closure of vet vessels. If a patient has a stent failure, you will notice that they're going to have signs of infarction. They may have chest pain, ST elevation, and although this is very rare, you need to monitor for this post PCI. Another risk is going to be bleeding from that insertion site. Think about it. You went in through an artery. Arteries are high pressure systems. You're always at risk for bleeding, or you could look out for hematoma formation. If you develop a hematoma, you need to hold pressure really, really hard. Sometimes they use sandbags. And you have to worry about ischemia to that sheath site. Think about it. Example, when they go in through the radial artery, a lot of times they'll use something called a TR band. It looks like a little watch. But what's going on is they have this thing on your arm and they have a balloon pumped so that it is compressing your radial artery. So you won't bleed, but it's also decreasing that blood flow. And over time, you're going to slowly decrease a little bit of air, usually about 3 milliliters every 10 to 15 minutes once the cardiologist placed the order. But in that meantime, this can lead to severe limb ischemia. So you need to do very meticulous neurovascular assessments. For example, when I have a patient that comes back from the cath lab, I have to do 6 15-minute neurovascular assessments, and then I switch to 30 minutes, and then I switch to an hour. And that is just to ensure that if the patient is developing ischemia, that I am promptly catching it so they don't lose an extremity. And patients may also have a reaction to that contrast dye. So you need to assess for things such as a shellfish allergy, and you need to monitor renal function because remember, a patient who's had an infarction, they are not perfusing, so they may have poor perfusion to the kidneys, and then you add dye to it, and this can be very harsh on the kidneys. Remember how when a patient has an ischemic stroke, we have that 3 to 6 hour window to administer thrombolytics because at that point the risk versus benefit is going to change. Well, we have the same thing with thrombolytics. And thrombolytics are going to be used if time for a PCI will take greater than 90 minutes. And our goal is to administer those thrombolytics within 30 minutes of the patient coming to the hospital. And with thrombolytics, we have a much longer window with myocardial infarction, up to 12 hours of symptom onset. And we'll use things such as alteplase, which will ultimately dissolve that thrombus. There's a high risk of bleeding, and a patient must complete the checklist prior to administration because there are contraindications. You have your relative contraindications. That's when we're going to say, hey, is the risk of this versus the benefit we have to really consider, because the patient is going to be at high risk. But when the benefits outweigh the risk, you're definitely going to do it. That's going to be patients with severe hypertension, prior ischemic stroke within 3 months, recent bleeding. They may have things such as pregnancy, apted peptic ulcer, and current use of anticoagulants, but we're still going to administer it if the INR is less than 1.7. And your absolute contraindications are going to be things that disqualify the patient for thrombolytic therapy, and that's going to be any prior intracranial hemorrhage, any type of cerebral lesion such as cancer, active bleeding, and significant closed head or facial trauma within 3 months, because at this point, the patient is at much higher risk for bleeding to where the benefit is just not worth that risk. A coronary artery bypass graft or CABG or open heart surgery is going to be a very invasive procedure. And with your traditional CABGs, a patient is going to require the use of a cardiopulmonary bypass because the heart is going to have to stop beating and you still need to reperfuse the body. And a lot of times you'll see chest tubes, mediastinal tubes, and sometimes pleural chest tubes are going to be placed following this procedure too. And with this, you need to monitor your drainage, make sure it doesn't exceed 150 milliliters an hour. But just remember, if a patient has open heart surgery, they are having major surgery. So it's important to monitor fluid electrolytes and to appropriately manage the patient's pain. You need to monitor their telemetry, vital signs. You want to monitor for signs of hypothermia, bleeding, hypotension, hypertension, neurological impairment, and cardiac tamponade. And I'll talk about that in a different video. And these patients are going to be at high risk for atelectasis. So it's very important that we focus on early movement and ambulation on patients that that's appropriate for. You will see that with the acute myocardial infarction and following this, there are going to be some priority medications for patients. And many of these are going to be lifelong therapies. For example, if a patient was placed a stent and in that acute infarction period, you're going to see aspirin given. Patients who have stents placed will also be on aspirin and Plavix lifelong. And remember, that's because when you have a stent, platelets are prone to aggregate along that stent, which can lead to obstruction and reinfarction. So we're going to give these platelet anti-aggregants to prevent that buildup of platelets. You will also see heparin or Lovenox given in that acute period, and that's going to be to prevent the expansion of that infarct. Remember, this is not a clot buster, but it's an anticoagulant, so it'll kind of help limit the size of that infarct. Often patients who have had an infarct will be started on either lisinopril, an ACE inhibitor, or you may see an ARB used. And that is because best practice shows that after an infarction, that this medication can help decrease mortality. Morphine, that's going to be recommended for that pain relief, because think about it, when we're in pain, our oxygen demands are going to increase. You will see often that patients will be prescribed beta blockers such as metoprolol following an infarction. Nitro is going to be used in that acute period. Obviously, not if they're hypotensive or if you suspect an right-sided MI. Statins are going to be part of a patient's therapy because we want to limit that cholesterol. We want to treat possible high cholesterol. And even if a patient doesn't have high cholesterol, they're still going to be administered these statins as a type of prophylaxis or prevention method. And I know you're probably familiar with the term MONA. That used to be, anytime we talk about an infarction, it'd be MONA. MONA is so outdated um, because it doesn't focus on the ultimate goal, which is reperfusion therapy. And we can still go back to MONA to support the patient, but again, what is your goal? Reperfusion. So you may see morphine, oxygen, especially if your O2 saturation is under 90. At this point, the patient is having a perfusion issue, so oxygen isn't going to hurt. Nitrates, obviously your nitro, but not with that right side. And you could still administer that aspirin. You have that patient chew that 324 milligrams of aspirin right then and there. And that's going to help prevent that expansion of that MI. But again, MONA is very outdated because it doesn't take into account treating the underlying cause. There is another mnemonic that you may or may not have heard of because it's less known. And remember, evidence based practice takes a long time to go into clinical practice and into our textbooks. But the suggested mnemonic is going to be thrombins 2. And this is part of your American Heart Association, your ACLS. This is part of their algorithm. But the goal is it's going to expand on that MONA and include therapies such as your beta blockers and your statins, as well as incorporate that importance of reperfusion, whether it's through surgery, your PCI or your CABG, or through the use of thrombolytics. And this is just a much better mnemonic for treating the entire clinical picture of that myocardial infarction. There are many complications of an acute MI, and I'll just discuss some of them. Obviously, your patient's going to be at risk for infarction extension. So the goal is reperfusion therapy so that the infarct does not increase or worsen. You may have dysrhythmias, cardiogenic shock, cardiac tamponade. You could have heart failure, and this could be left-sided, and sometimes the left-sided can even extend to the right side. Or if you've had a right-sided MI, you would have right ventricular failure. You may have structural defects such as the ventricular aneurysm, and you may have some papillary muscle rupture or dysfunction. You may develop a type of autoimmune pericarditis called Dressler syndrome because the heart is going to try to remodel itself after the damage. Because what does our body like to do when things are damaged? It wants to fix it. And again, that's not always right. And a patient can develop sudden cardiac death.
The role of the nurse does not end when that acute infarction has resolved. In fact, nurses are going to play a significant role on the long term treatment of a patient who has had a myocardial infarction. We are going to provide a lot of education. We are going to be part of cardiac rehab, which is a medically supervised program that is going to help patients improve their cardiovascular health after the heart attack. It's going to be individualized to their specific needs. We're going to help the patient with an exercise regimen, on consuming foods that are low in saturated fats, low cholesterol, low sodium diet. We are going to encourage the patient to participate in smoking cessation and monitoring their blood pressure, blood sugar, and following up with the physician regularly to have their cholesterol levels checked. We are going to educate them about maintaining a healthy weight and other things that they can do to reduce their risk of reinfarction.